Akhil sir, are we good to go?
Yes, sir, you can good to go.
And I'm just waiting. Dr.
Dr.
Kapoor
Ron,
as well.
Dr. Ron, can you
Yeah,
hear
yeah,
me?
please go ahead.
Yes, sir.
I can't see my image. I can't see my.
Sir, I think your camera shutter is off.
But we could see you just a while ago. Yeah, now we can see you, sir.
I can't see myself. Anyway, okay. Anyway, all right.
So should we begin then?
Yes, yes.
Okay, wonderful. So thank you so much, everyone, for joining in today evening for this wonderful session that we've planned for you on supportive care symposium. So, as you are well aware that in cancer patients, it's not just the treatment for the underlying cancer, but the supportive care also, which indirectly helps in the quality of life of the patient and helps in the healing as well. So, with this. We've devised this wonderful agenda here for you, and we'll start today with cancer related anemia beyond correction to clinical impact, where we will have Dr. Akhil Kapoor sir, who's going to talk to us about cancer related anemia and translating evidence into real world supportive care in practice. So of course, Akhil sir doesn't require any introduction from our end. Sir is a professor and in charge of the Department of Medical Oncology at the Tata Memorial Center at Varanasi. Sir is a distinguished medical oncologist with 15 plus years of experience and has special interest in targeted therapies and immunotherapies. Sir has more than 166 publications in medical journals, reputed medical journals, has been a part of various clinical trials, national and international, and has 15 awards and honors under his belt. So, sir, over to you to help us understand cancer related anemia beyond correction and clinical impact. Over to
Yeah.
you, sir. I'll stop sharing my screen.
Yeah. Thank you. Thank you. So, as highlighted, it is very important to understand these supportive care concepts, because what happens, we might keep on in having better treatment option, but at the same time, we need to have better supportive care so that outcomes of our patients are improved and our patient can get the best possible treatment. So I will be trying to start screen sharing. Yeah.
Yes, sir. Screen is visible. Perfect.
Yeah.
Please go ahead.
So I will try to cover some important points in the first 10 to 15 minutes, followed by we'll try to have some interaction with the panelists so that we can bring out the real world scenarios and what is important to understand. So let's move ahead. So what we know, iron deficiency anemia is very, very common, and sometimes we underestimate it. Even the data which is there from the Western country will underestimate the data from our country, because iron deficiency is much, much more common in our country. And whenever I do test iron profile, anemia profile in our patients, I tend to get 60 to 70% with some or the other deficiency, not only iron, sometimes B12, sometimes folate, but yes, iron deficiency remains the most common. If you see along the solid tumors, GI malignancies and genitourinary malignancies, these are two malignancies which have one of the highest incidence of iron deficiency anemia. Genitourinary, definitely reasons are very well understood, loss of blood through the natural pathways. At the same time, GI malignancies lead to continuous loss of blood, which is not easily recognized and definitely leads to a significant amount of iron deficiency. So if you see this data, in this data also, CA pancreas, GI esophagus, but the most common, 40% more were seen in lung, gynae, and myeloma. So there are multiple factors. This is not only one factor. It is disease-related factor, treatment-related factors, and also there is effect on the kidney due to the treatment or due to the disease per se. For example, in myeloma, we have seen that the disease itself causes kidney dysfunction, leading to suppression of the kidney, leading to reduced erythropoietin secretion by the kidney, leading to a deficiency. And as I highlighted, B12, iron, folate deficiency is very, very common in our country. B12 is very common in vegetarians, and we see a lot of patients who have are vegetarians and are B12 deficient in our practice, and it is very common for us. Also, when the immune system becomes activated and there is an inflammatory environment, what happens if iron is taken in the normal diet, that is also not well absorbed. We know that due to obvious reasons, the patient is unable to get sufficient iron, even if iron-rich food is being taken. So there is a two types of iron deficiency: functional and absolute. Absolute deficiency, there it is definitely due to reduced intake or the blood loss, which is the most common scenario. Functional iron deficiency is also not uncommon. There is iron store in the body, but it is not being able to be utilized. So in functional iron deficiency, you need something more than iron. It is definitely erythropoietin or darbepoetin, which we utilize very, very commonly in our practice. So if we see iron transference saturation, iron by TIBC is utilized for the same. In both of the scenarios, transference saturation will be low, but ferritin values will be different. It is typically more than 100 in functional iron deficiency and less than 100 in patients with absolute iron deficiency. So hypochremia is much, much more common in absolute iron deficiency. And if you see serum transferrin ratio, it will be elevated while it will be normal in functional iron deficiency. Also, what are the consequences? It will reduce to definitely significant amount of fatigue, reduce quality of life. The patient will continue to tell about थकान लग रही है, परेशान है, they are not feeling good, overall performance status remains poor. All these lead to multiple problems and less satisfaction with the treatment and even default from the treatment. So this is very, very important. And if HB is below 10, in fact, in our country, we take hemoglobin 9 and sometimes even 8 sufficient for starting chemotherapy or even radiation therapy or even surgery. But actual HB cutoff throughout the world is 10. 10 should be a very important cutoff. Though we may accept hemoglobin 9, HB of 8, it is very, very low cutoff, and we should not neglect hemoglobin below 10 anytime. It is our practice to test anemia profile in 100% of our patients, even if they are presenting with HB of 11 or 12, because we know there might be B12 or marks deficiencies which can become unmarked during the treatment. So it is better to correct them beforehand. For example, if there is a deficiency and you are correcting it, it will take a lot of time for the marrow to recover. So it is always to correct them as early as possible so that before the stress, you are already having sufficient reserves. So as I discussed, the advantages of proper correction of anemia will be improving HB levels, improving quality of life, at the same time reducing the need of blood transfusions. Also, there is data which is evolving, which is clearly showing that if patients are receiving blood transfusions, immunotherapy efficacy is also reduced, because blood transfusion will lead to some changes in the microenvironment throughout the body. It will lead to some cytokine release that will lead to reduced immunotherapy action. And we know that immunotherapy is there in every cancer now, in every solid tumor at least. And if we are not able to give treatment benefit from immunotherapy, this is definitely going to reduce the benefit of the entire treatment. So HB recommendation from the ESMO is HB 8 to 10 and above. It is a dose of 1000 milligram. IV iron is recommended in both absolute and functional iron deficiency. HB, if it goes below 7, or sometimes we do not only see HB levels. Sometimes if we see how much patient is symptomatic, patient is having tachycardia, patient is having dizziness, that becomes itself an indication for transfusion, because we will see a patient who is having a significant body weight. HB of 8 is also very low for that patient, because if weight is close to 90 or 100 kg, then HB of 8 will also be low. So it is not absolute value, it is a relative, and we need to understand and utilize accordingly. So these are the options which are available: blood transfusion, erythropoietin, darbepoetin, and IV iron. As we discussed, they are different indication and benefit, and we need to utilize each of one of them at the correct time. Erythropoietin and darbepoetin, this is another very useful drug which we utilize in our practice. One important point is that erythropoietin or darbepoetin should be utilized whenever mostly in settings where we have advanced diseases. because there is some data that erythropoietin or darbepoetin might reduce the survivals in curative setting. So that is why we tend to reserve in an advanced scenario, but it can be one-on-one selection in suitable patients. IV iron is very, very important. In fact, our oral iron utilization is very, very low. Oral iron itself causes various problems, reduced appetite itself, changes in the color of the stool. We want to recognize melena if it is occurring, and oral iron will mask that. So we don't want these problems. So oral iron utilization in our practice is nearly zero, and we utilize more and more of IV iron. Ferric carboxymaltose, this is a molecule which we have utilized from more than 5 to 7 years now. This is very, very most common drug iron preparation utilized in our practice. It is a stable ferric state as a complex with a carbohydrate polymer. You can see this is a polymer with a carboxymaltose shell, and iron is the core. And it is this polymer is designed to release utilizable iron to iron transport and storage proteins in the body, that is ferritin and transferrin. So it is stable and formulated as a colloidal solution with the physiological pH. And due to the stability of the complex, it does not release ionic iron under physiological condition, and it is present in the carbohydrate case. There are multiple other formulations. Iron sucrose was the most common utilized iron formulation around 10 decade back, but I think it is not utilized nowadays. In our when we were doing MBBS, we used to learn about iron sucrose injection, how it is given, Z-track technique, but all these are obsolete now. And most of the time we utilize ferric carboxymaltose. I have not utilized any other iron formulation from last more than 5 years actually. This is a standard TMH practice to utilize ferric carboxymaltose. The advantages are very well visible. You can see the half-life is good, large, 16 hours, and it is matching with the ideal IV formulation. pH is near neutral, isotonic, and there's no antigenicity or low antigenicity, while others have higher antigenicity. It requires 15 to 20 minutes injection, and 1000 milligram infusion can be given easily, while iron sucrose cannot be given more than 600 milligram. See the data from lymphoid malignancy. This is also very good. IV iron alone corrects anemia and iron deficiency in cancer patients with lymphoma undergoing antineoplastic therapy. There are multiple other data sets are available. This is for the solid tumor camera study, which came in 2022. Patients received IV supplementation with carboxymaltose according to ESMO guidelines, and quality of life was assessed. And this clearly showed all the quality of life parameters was utilized as a parameters: emotional, physical, social well-being, anemia, total fat anemia. These all were improved significantly. This study first demonstrated that there is increased quality of life in oncology patients with iron if we are able to reduce iron deficiency. So anemia is definitely a independent prognostic factor for survival. This is also proven. And if the patient is having anemia, the risk of death is increased by 20 to 75%. Head neck cancer, it is increased risk of death by 75%. So anemia is associated with shorter survival. Why 1000 milligram doses are utilized most commonly? If you calculate for Genzoni's formula, 980 milligram dose is coming for a patient with 50 kilogram patient with HB of close to 9 gram per DL. 1000 is standard dose, which is published in majority of the international publications. And there is also data from Indian setups, including studies from AIIMS Rishikesh. One more data is under generation at our center, which includes ACTREC and TMH Varanasi. I will be coming to that data as well. So this is the Indian clinical data which are available. This is the study of IV ferric carboxymaltose, which has been presented already. Patients 77 aged more than 12 years. Maximum dose of ferric carboxymaltose was given 1000 milligram, and response rates were significant. And infusion-related toxicity was very low. And key observation included significant hemoglobin rise up to 3 to 4 gram HB. So this is very important. At least we will see at least 1 gram percent increase in hemoglobin in majority of the patients. There's this data. There's also retrospective data, which is they published already in Indian Journal of Cancer Education in 2023 also. HB improve was significantly improved with ferritin and transferrin saturations getting improved throughout when the iron carboxymaltose will. There's some comparison about FCM and isomaltoside as well, because isomaltoside is another good formulation. But the problem is that isomaltoside is associated with significant infusion reaction, and we don't want to have the patient any significant infusion reaction, because this will lead to a significant amount of psychological issue for the patient, and we don't want any extra added disadvantage for giving IV iron. So overall risk of hypersensitivity is lowest with FCM. This is the Netherlands study, and isomaltoside around 500%, it was low to moderate. You can see 8.7% any risk of hypersensitivity, and moderate to severe hypersensitivity occurred in was significant, and it ranged from 0.3 to 6%. So ferric carboxymaltose is having least problems, and it is labile iron is also one of the least available. So the problem is that the good thing is that anaphylaxis reaction, it is least with IV iron. There is also data of prospective study, which is already, as I discussed, it is recruiting at our centers, and it is taking patients 18 years and above, the patients who are taking treatment for breast cancer and are on follow-up and have completed the planned treatment. For example, the patient is on adjuvant hormonal therapy, patient is on adjuvant PARP inhibitor, patient is on adjuvant CDK4/6 inhibitors with hormonal therapy. HB is between 8 to 10, and transferrin saturation is less than 20%, regardless of HB level. So we want to see the change in hemoglobin levels at 1 month, plus minus 7 days after ferric carboxymaltose injection. So we have planned the recruitment of 100 patients. 85 patients have already been recruited. This is the data of interim analysis of close to 49 patients, where 48 patients data were included for the analysis. You can see 43 patients experienced an increase in hemoglobin after treatment. 4 patients did not have an increase, or in fact showed some decrease. Total number of patients positive ranks is transferrin saturation improvement is 28, and ferritin levels also improved after treatment. So out of 48 patients, 43 patients showed an increase in hemoglobin level, and the median value of increase in hemoglobin was 1 gram per DL. And you can see transferrin saturations in non-responder patients. If you see, transferrin saturations were not so high in such patients. So it is important to understand. Also, the patients who are receiving targeted therapies like CDK4/6 inhibitor, the environment is more myelosuppressive. There's some reduced benefit, and it will take some more time, not only it will take more time actually. So these patients were on immunotherapy and targeted therapy with endocrine cancers. These will remain a problem, but yes, they will take some more time. If patient is only on hormonal therapy, the response rates are much faster. You can see from the available data. And also, if patient is having multiple sites of disease, what will happen? The patients will have less benefit, or it will take more time. And in these cases, when the environment is already myelosuppressed, it will require not only iron, but in metastatic cases, that is why we try to combine iron with darbepoetin as well, so that we can get better outcomes. So if hemoglobin is below 10, use IV iron in combination with darbepoetin in patients with advanced disease. If patient is having hemoglobin between 8 to 10, or transferrin saturation is below 20%, it is already an indication of IV iron, and ferric carboxymaltose 1 gram is the standard dose which you utilize, and repeat CBC as per the requirement. Most of the time we are able to get it repeated because the patient is on some or the other treatment. And if there has not been significant rise, you can repeat the iron and ferritin levels, and if it is still low, give one more dose of ferric carboxymaltose. If the weight is below 50 kg, you are repeating the dose. You can repeat a dose of 500 milligram. If the weight is above 70 kg, in fact, definitely you need to give much higher doses. 1,000 milligram dose can be repeated easily after 3 weeks. So this is what we do in our practice. So these are the available data sets. We have tried to see if the patient is having more metastatic sites. Definitely there is some chances of being non-responder, as I discussed. That is why it is important to combine IV iron, ferric oxybaltose with darbepoetin or erythropoietin in patients with multiple and higher disease burden. And targeted therapy plus endocrine therapy were the most common regimen. And whenever the patient receiving CDK4/6, as I highlighted, these have some less chances of response. And this is what is the reason. So to summarize, the patients receiving treatment on cancer-directed treatment, breast cancer patients or any other cancer, as we discussed, multiple cancers, ferric carboxymaltose remains a very important parameter to be utilized at the correct time so that the patient can get the best possible results. With this, I would look to stop here and let's have some discussion. I invite the panelists as well. Dr. Prabhat, he's assistant professor at BCH Mullanpur and Chandigarh. Dr. Anupam Mahanta, he's from Guwahati. Dr. S.V. Saju from Meenakshi Mission Hospital, Madurai. Dr. Shashanka at Medanta, Lucknow. And Atul Sharma, sir, he is chairman of the medical oncology and he has been my teacher. He has taken almost all of my examinations, including DM, DNB.
Excuse me,
Yes.
this is Pratul. I think there is some confusion.
Okay. Okay, you
My
are Atul sir's student, Dr.
yeah, I'm also a student.
Okay. Yeah,
So
yeah.
somebody
This is
has
a
by
common
mistake.
problem with Dr. Atul. It's fine.
Yeah.
Okay, fine. Thank you for highlighting. So let's start with the discussion. I request Dr. Atul to comment. So how you decide between oral iron, IV iron, and erythropoiesis stimulating agent and RBC transfusion when you are deciding the treatment for your patient?
So I think most of the times it is IV iron. So decision between oral and IV is not that difficult because
Yeah.
simultaneously our patients are on chemotherapy and many times they have other GI side effects. They are going through GI symptoms. So it is not usually possible for them to, not possible for us to prescribe and not possible for them to tolerate oral iron. So if somebody is iron deficient, so first is to supplement iron. So erythropoiesis stimulating agent, their role comes once we have replenished the iron stores, then only their roles come. And regarding the red blood cell transfusion, the goal is actually is to avoid any blood transfusion unless it is necessary.
Yes. So very crisp and useful answer for Dr. Atul. I think this makes the point very clear. Utilize IV iron and we'll come to that which formulation. So Dr. Prabhat, I request your comment. Which is your preferred IV formulation in your practice and which you utilize in your practice? Which formulation?
So I think FCM is the most commonly used formulation. We've not used iron multiside too much as of now, but I think FCM is fairly well tolerated and it has good results.
Yeah, I think we all are very comfortable with FCN at present, as I discussed also. From last 5 years, I have not utilized any other iron preparation, and the comfort level is very high, and we rarely get infusion reaction. Sometimes the infusion should be between 15 to 30 minutes. That is sufficient. If it is a faster, then there's some more chances of infusion reaction, but otherwise, we don't very commonly see infusion reactions. Thank you, Dr. Prabhat. So now I request Dr. Mahanta for his comments. So when you're sequencing the treatment, uh, what is the time point when you decide you should consider iron replacement? Is it a significant anemia or will you check anemia profile at the baseline itself? What is your practice, Dr. Mahanta?
Yes, anemia is very common in our northeastern parts because of the different hemoglobin of it is.
Yeah.
So we have to presence of because we commonly see between 8 and 10 in most patients because of the hemoglobin disease also. So in chemotherapy patient, if we are going for chemotherapy or immunotherapy, we I routinely see iron deficiency or other deficiency status, and accordingly I plan. And regarding your using iron supplementation in chemotherapy, I usually avoid using iron supplementation along with the chemotherapy, and and particularly those who are taking cardiotoxic drugs like anthracyclines. I avoid concomitant infusion and usually prefer before the starting chemotherapy or in between the cycle.
Yeah, so very important comment. Even with tetracycline as advised, there is some increased risk of oxidative stress, and there's some uh, theoretical risk of increased cardiotoxicity as well, as Dr. Mahanta was trying to highlight. So it is very important to correct iron deficiency at the baseline itself. So don't wait for anemia to become uh, overt. If it is already overt, most of the time you will require some other and sometimes if HB goes below it, most of the time packed RBC will be required. So it is always good to give iron replacement before starting the treatment itself. When the patient is still on the workup, for example, biopsy is still and is being planned, you can see at that point itself. If the patient has come to you after biopsy, then also before the workup, if you are doing the workup and any other tests are pending, do include anemia profile and try to correct it beforehand. I think that is what Dr. Mahanta was also trying to highlight. Yeah. Let's move to Dr. Shashanka. I request your comment. Yeah.
Yes, sir. Yes, sir.
Yeah. So what do you try to see this in your practice at the baseline itself in all your patients, or you reserve it when the anemia has already become overt?
No, sir. I usually patient coming with anemia, I assess the iron status. I don't do the baseline iron status in all my patient.
Mhm.
Only in patient coming with reduced hemoglobin level from from the normal range, I usually go with the nutritional whole of the nutritional status. Not
Okay.
only iron, but also the vitamin B12 and folate.
Well, okay. So it's important message. Apart from iron, always try to see B12 and folate. As I highlighted, B12 is also very commonly deficient in patients who are vegetarians, and it is very common prevalence of B12 deficiency in UP and Bihar. And we see a lot of patients with significant B12 deficiency. We have seen B12 level of just 25, 30, 40, 50. So these are very common values for us actually. And folate deficiency is also not uncommon. We have seen folate levels of 2, 1. So it is very common to have these deficiencies. And only correcting iron will not help in these cases. We know that. So it is good to have a anemia profile. And it is in our practice, we do it for 100% of our patients who is consulting medical oncology department at our institute. Anemia profile is a part of the workup. It is like viral marker. Every patient is getting viral marker. Every patient is getting anemia profile at who is visiting Department of Medical Oncology at TMH or RMC. Let's come to Dr. Saju. Dr. Saju, do you agree with this concept of testing anemia profile in majority of your patients at the baseline itself, or what is your thought? See, there might be differences in the practice, but if the resources are there, would you consider doing this at the baseline itself?
If resources are there, I would definitely do, because the incidence of anemia in our patient population is nearly 50 to 60%. So it's ideal to do the iron profile and correct the iron reserve in the body, because that has huge impact on the subsequent tolerance to further chemotherapy as well.
Yeah, so this is very important. Our aim is not only to correct anemia, our aim is to have good continuation of the treatment, good intensity of the treatment, those intensities, those density, all these matter in the outcome as highlighted by Dr. Saju. So it is very important to correct them at the baseline itself, and it makes sense to correct anemia profile, that is iron apart from B12 and folate in the routine practice. And if a patient is presenting, for example, cervical cancer, the patient is planned for radiation treatment, and patient has been referred to medical oncology for concurrent chemotherapy workup. So I think it becomes more important because there's already clear-cut data. If hemoglobin is less, radiation will also work less. So it is, though radiation department might do it themselves, but if they have not done the anemia profile till and they have referred to medical oncology for concurrent chemotherapy, I think it is our responsibility to do this and correct hemoglobin levels for the best outcome for our patients. So I think the data is good. We have seen very good results with ferric carboxymaltose in our practice. There is no doubt that the outcomes of our patients, including the quality of life, is significantly improved. There's very strong data. This is not a single data. This is across the trials, across the countries. We have seen data from Netherlands. We have seen data from our own country. We have seen data coming from various other countries, including European countries, and where anemia is an important issue. And in our country, we have heard views from north, we have heard views from east, we have heard views from south, and it is very common. Anemia is common throughout the country. It is not region specific. 50 to 60% is the ballpark figure. It can go up to 70%. Sometimes it can go up to 80%, depending on the primary tumor site. So I think it is very important to have a proper anemia workup, a timely correction of hemoglobin reserves, that iron reserves at the baseline itself. And if it is anemia of chronic deficiency, definitely iron needs to be combined with other agents, including erythropoietin or darbepoetin in advanced patients. Definitely there is some risk of embolism and DVT, but if HB is below 10, it makes sense to utilize this, and all the guidelines are also aligned with the same. There is no doubt about it. So I think in the interest of time, I would like to stop here and hand back to the Genova team. Dr. Ronak, you can take it forward. Thank you.
Thank you so much, sir, and thank you so much for the expert panel to give your clinical pulse regarding cancer care in anemia care in cancer patients. So thank you so much, sir. With this, I think we can move ahead. So So the next session that we come to is regarding cancer treatment induced bone loss, early recognition and effective management, where Dr. Mohit Agarwal sir, who's the principal director and head of the medical oncology at Fortis Hospital, New Delhi, will be giving us a talk regarding the same. Sir, of course, is a distinguished medical oncologist with extensive experience in the management of solid and hematological malignancies and is actively involved in multiple clinical research, academic medicine, and oncology education. Sir is the DNB thesis guide and examiner of the National Board and has various clinical trials and research experience, especially in breast cancer, lung, biliary tract, and other malignancies. Sir, we are keen to learn from you, and over to you to take us through what exactly is beyond bone density, the expanding role of denosumab, especially in oncology. Over to you, sir.
So thank you, Genova team, for such a warm introduction. And from anemia, now we move on to another very important topic, another important topic in terms of oncology, and as it is as well. And I must say that to emphasize on what Dr. Akhil Kapoor just said, we test, these iron profiles, B12 folate in each of our patient. And it's surprising to see the incidence and percentage of the patients who actually have near about normal hemoglobin level, but they are actually deficient, and they are bound to get much more complications when the treatment is done. So these should be tested at baseline. From there, now we moved on to a very important topic, which was beyond the bone density. So we here understand the expanding role of denosumab in oncology. So next slide. So why does the bone matter? Actually, bone health matters. And we know that bone loss is a major problem as it is in India, and especially in oncology, because it would obviously lead to fragility, fractures. Patient would be complaining of chronic pain. They'll be dependent upon the movement. Interruption of cancer-directed treatment would be there. And there are a lot of chances of fractures. And if you see here in the survivorship care, preventing a major fracture like a hip fracture or vertebral fracture, which would make a patient bedbound, is really a very clinical significant point. And hip fracture actually carries roughly a 20% 1-year mortality in general population. So that is the importance. So I have seen many of the patients who are elderly, they are doing very well with their general things, but when they have a fall and subsequent to a fall, they develop a hip fracture, and subsequent to that, their performance status drastically reduces, that they are not able to continue their treatment and just finally succumb. So these skeletal related events in the metastatic disease directly reduce the quality of life and obviously increases the cost, hospitalization and the care which is required. So approximately 20% is the 1 year mortality after hip fracture. That is something to be understood. And what are the reasons behind bone loss in an oncology patient? There are multiple, but where you have is important one are endocrine. You have chemotherapy induced senescence, you have usage of glucocorticoid, and obviously the tumor induced osteolysis. So these are some of the things which we really need to take care, so the continuum of care is maintained in these patients, and fracture prevention actually deserves the same structured attention as disease response monitoring. Next slide. So if we see the burden in India, about 61 million cases are estimated to have osteoporosis, and 80% of those patients are actually women. And we know that there are some hormonal factors in women which predispose them for all these factors. And 1 in 3, that is 33% of the postmenopausal ladies, are affected nationally. So that is big, the burden. And this is, the onset is also earlier as compared to the Western population, probably because of the lifestyle and the diet. So if you see the DEXA-based surveys from the postmenopausal osteoporosis prevalence, it is about 30 to 37%. And with osteopenia, it would be around 50%. So every third woman and roughly 8 men in India is estimated to be affected by osteoporosis, which is huge. And this is compounded additionally by vitamin D deficiency, very common, as we like something like an iron deficiency, and lower average BMI bone mass than Western cohorts. Our bone masses are actually less, our muscle mass is less, making us the Indians more prone for fractures. So baseline population risk is the backdrop against which the AI and the ADT are layered in oncology patients. And AI and ADT are, crux of treatment in for few of our malignancies. So these Indian patients actually often start cancer-directed endocrine therapy from a lower baseline bone reserve than the Western trial population, and this predisposes them more for these problems. Next slide. So there are also screening gaps in routine oncology practice. So whenever we start with ADT or AI, I don't think that we always get a baseline DEXA done, though if it should be done, and it really makes the difference in the outcome of the quality of life of the patient. Vitamin D testing is now being done very commonly, but I'm not sure whether it is being done everywhere. But I think vitamin D deficiency is very common in India. It has some implications in malignancy progression as well. So I think vitamin D testing is must. Dental clearance, I know this has been taught long back that whenever we are starting these anti-resorptive therapies, the dental clearance should be taken and an initial dental assessment should be done. But I really feel that we lack in these aspects, and bone health follow-up often lapses when patients are established on endocrine therapy. And in our gist of getting those normal scans and ultrasounds and x-rays and blood tests, usually we forget getting these DEXA scans. So a practical fix is that build DEXA, vitamin D and dental screen into the AI ADT initiation checklist. And this is, I think, very important. Whenever you initiate a patient on AI or ADT, check DEXA, check vitamin D and dental screen, triple D. Assign one clinical staff member ownership of bone health follow-up, if it is possible, or you can do it yourself as well. And set up an automatic reminder for repeat DEXA at 1 to 2 years. We normally do DEXA for most of our patients, annually. Next slide. Okay, now the question comes that how is this cancer treatment induces bone loss? So we see here that there is some sort of an accelerated bone loss by these anti-cancer therapies. And as I have mentioned previously, it is most commonly by estrogen deprivation from aromatase inhibitors in breast cancer, or something like a testosterone deprivation from an ADT. Now, bone loss begins within months, and it is typically more rapid than what you actually lose because of the age. And post-menopausal bone loss is already there, and it actually increases the effect of everything. The clinical consequences that you have a low bone marrow mineral density, deteriorating microarchitecture, and a measurably higher fracture rate during and after the cancer treatment. And if you see, the population which is highest at risk would be obviously the breast cancer, because they are usually treated by AI, and prostate cancer because ADT is very commonly given in these patients. And we see here that the anti-resorptive therapy actually can mitigate these side effects by altering the cycle of these transforming growth factors and BPMs, and reducing these osteoclast activity, which I'll be talking more about, and hence affecting the bone remodeling. Next slide. So the central target in bone absorption is this rank ligand. And we see here that the osteoblast actually leads to an increased expression of rank ligand. The rank on the osteoclast precursors are then interacted, and there is activation of the osteoclast. Now, when you give estrogen or ADT, it removes the brake on this pathway via this molecule, which is known as OPG. And hence, it leads to an activation leading to a net bone resorption. Now, if we block this rank ligand, what will happen is this OPG won't do anything. Then a mechanistically rational strategy would be that, in any of these osteoporosis, you block this rank ligand blockade. And when you blockade it, the pathway does not go further, and the osteoclast activity is not activated. And this is basically the biological basis for denosumab used across breast cancer, prostate cancer, and even any other malignancy where there is some sort of a metastatic disease, bone metastatic disease. Next slide. So if we see the mechanism of action, it is very well shown over here. What is denosumab? It is a monoclonal antibody, IgG2, which binds rank ligand with very high affinity and specificity. When it binds the rank ligand, it prevents the rank ligand interaction on the osteoclast precursor, which you can see like something like the octopus in the photograph. And this results in what happens is that it suppresses the osteoclast differentiation, activation, and survival. And when the osteoclasts are not activated, the bone turnover reduces, and resorption reduces, so the BMD increases. So the onset of action is actually rapid, and it is usually given by subcutaneous injection. If you see the bone turnover, it markers fall within days. So it is not months, it is with days the action happens. Now, why not a bisphosphonate? Because this denosumab has some specific advantages, which is that you do not require any renal dose adjustment, which is required in a case of bisphosphonate. It does not accumulate in the bone matrix long term, and it is a reversible effect. So bone turnover rebounds if stopped. So this is very important. I recently had a patient who was on this sort of therapy, and she developed some sort of fracture. So when we reviewed the literature, it was rarely found that when you give these injections for a very long time, the bone actually becomes like a marble, and hence you can actually develop these sort of symptoms where the patient would have a fracture in fact because of these molecules. Now the good thing about this was that once we identified it, we removed this denosumab part, and again the bone activity and remodeling has started, which would not happen in the case of a bisphosphonate. And again, this is just a subcutaneous injection, and it is not intravenous. Next slide. So what are the indications? As I have mentioned previously, in men who are at higher risk for fracture because of an ADT, specifically in metastatic prostate cancer, to treatment to increase the bone mass in women at high risk of fracture, receiving AI, example in breast cancer, treatment of bone loss associated with long-term systemic glucocorticoid therapy, adult patients at higher risk of fracture, osteoporosis in post-menopausal women, and also in men with osteoporosis at high risk of fracture. And what are the recommended doses? It is 60 milligram denosumab as a single subcutaneous injection once in every 6 months into the thigh, abdomen, or upper arm. But what you really need to understand over here is that once you give this injection, you should be sure about your calcium levels, that they are within the normal range, and the vitamin D supplementation and vitamin D levels should be normal. Otherwise, it increases the deficiency in terms of vitamin D. Next slide. So coming on to the evidence in the breast cancer. So why AI actually increase the fracture risk? So the typical duration of AI is at least 5 years, and maybe more than that as well. So AI is basically nearly completely suppress the peripheral estrogen synthesis in postmenopausal women, and estrogen is a major protective signal for bone via suppression of rank ligand. Now, once this estrogen is suppressed, this rank ligand activity is increased. Without that protection, what happens is that this osteoclast activity is increased, and the bone modeling happens for much more, and the density reduces. The clinical concern is not that this BMD number, it's the fragility fractures, that because the bones become fragile, even a trivial trauma will lead to some sort of fracture, and obviously bone pains. Patients keep on complaining that they have pain in their arms, legs, and bones. And because AI therapy is typically continued for 5 years or more, cumulative skeletal exposure is substantial, and we have cases who develop fracture because of trivial fall and etc., which would not have been the case had they not been on such sort of a therapy. Next slide. So this was the ABCSG trial, which was adjuvant denosumab in breast cancer, which was a multi-center randomized double-blind placebo-controlled trial, and it tested about 3,500 postmenopausal women, and it was randomized into a ratio of 1:1 of about 1,700 each. This was conducted across 58 centers in Austria and Sweden. And these patients were usually hormone receptor positive early stage breast cancer receiving adjuvant AI. And they were either given placebo or a 60 mg subcutaneous dose, which I have told you, which is a standard. The primary endpoint here was a time to first clinical fracture, and the trial was designated to test this fracture prevention and not anti-cancer efficacy. Later, some data was also there that this also has some sort of an anti-cancer efficacy as well. But this primary trial was for the fact that does it prevent these skeletal events in terms of fracture. Next slide. So if you see the primary fracture results, you can see here is a wide difference between placebo and denosumab. The graphs have separated from the beginning and they keep on widening up. So denosumab actually significantly delayed the time to first clinical fracture versus placebo. And one of the largest fracture reduction effect sizes were reported in oncology bone health trial. The regimen is simple: one injection every 6 months. And this is very, can be done on an OPD basis as well. If you see in terms of the relative reduction, it is a 50% relative reduction in the fracture risk of denosumab versus placebo. And this is actually the strongest breast cancer evidence base for denosumab as CTBI prevention with a 50% relative fracture risk reduction. Next slide. So if we also see the BMD changes, which would actually are helping in terms of preventing the fracture and even bone pains and everything. You can see here the blue curves are of the placebo, while denosumab is of the red curve, and these are the baseline changes in the bone BMD. And you can see here in terms of lumbar spine, the total hip, and the femoral leg, wherever the denosumab injection was being given, you see here the BMD was improving as compared to what was with placebo. So this injection twice per year has reduced the risk of clinical fractures in postmenopausal women with breast cancer receiving AI and can be administered without added toxicity, was the outcome of this ABCSG18 trial. Next. So there were some long-term outcomes as well, which was an 8-year end follow-up data, where they found that in the final long-term analysis, there was a marked reduction in clinical fractures. 201 fractures were in the denosumab versus 255 in the placebo, a 24% reduction. And the DFS was also improved with the denosumab, 309 versus 368, an absolute 9-year difference of 3.5%, and a relative risk reduction of about 17%. So bone metastasis-free survival and overall survival showed similar direction improvements in this single trial long-term data. So it was having some sort of an improvement even in overall survival as well. Next slide. Now some evidence about the prostate cancer. Next slide. So we understand again the ADT. ADT would actually work similar to that of an estrogen in female, where it would be again impacting the bones the same way as estrogen does in a female. And men who are on ADT are often older and carry additional independent risk factors, which is a low muscle mass, falls, and particularly relevant vitamin D deficiency. So unlike breast cancer, we still have a tendency to look into females as a AI therapy being given and something like an osteopenia or an osteoporosis. But we usually tend to neglect that in prostate cancer for a simple reason that even the meds are considered to be sclerotic. So one feels that, maybe it is not really required to actually monitor the bone health. But the other factor is the osteopenia and osteoporosis, which we actually neglect in only seeing in terms of prostate cancer, being a male and having a sclerotic met. So prevention should begin at the ADT initiation and not after the first fragility fracture. The fracture risk is increased, and the under screening is much more prevalent than the breast cancer. Next slide. So this was a HALT trial which was given as a denosumab in non-metastatic prostate cancer. Now, when we talk about use hormone sensitive prostate cancer and you tend to give denosumab in any of these such patients, people would raise a question about you that it does not have any advantage in terms of the metastasis. But here, what you are not targeting is the mets. What you are targeting is the bone health. So this was again a double-blind placebo-controlled trial, phase 3, about 1,500 men who were on ADT arm, 1:1 randomization of similar sort, denosumab 60 mg or placebo. Primary endpoint, the percentage change in lumbar spine BMD at 24 months. And what it came out with the fact was, you can see in terms of the graph, the lumbar spine BMD actually increased by 5.6% versus a 1% loss with placebo, a difference detectable as early as 1 month. So this is something remarkable that you see here at the end of 1 month, the moment the graph has started, it has just widened up, and this denosumab harm has just picked up over. The new vertebral fractures at 36 months occurred in about 1.5% of the denosumab group versus 3.9, which was a relative risk of 0.38, which translates to a 62% benefit. Next slide. So if we see now, one may argue that why not just give a zoledronic acid? What is really a necessity of going ahead with denosumab? But there is some data for the same as well. This was the phase 3 randomized double-blind trial with CRPC patients who had bone metastasis with no prior IV bisphosphonate exposure. These patients, because these patients had bone mets, the dose used was 120 milligrams subcutaneous every 4 weeks versus zoledronic 4 mg every 4 weeks. The primary endpoint, again, the SRE, which is, by definition, is either a pathological fracture, the spinal cord compression, surgery to the bone, or radiation to the bone. And the median time to first on study skeletal related event was 20.7 months with denosumab compared to 17.1 months with zoledronic acid. And this was actually a non-inferiority trial, so it proved actually P was 0.008 for superiority. And denosumab significantly delayed the median time to first SRE by about 3.6 months, meeting the criteria for statistical superiority, not just non-inferiority. So though it was initially non-inferiority which was tested, but it was much ahead in terms of, and it proved to be a superior medicine as compared to zoledronic acid. So this trial established denosumab as superior, not merely equivalent to zoledronic acid, for delaying the skeletal complications. So again, a very relevant data where we know that if possible, this should be the molecule of choice when you are dealing with bone metastasis. Next slide. Okay, now we have some broader solid tumor experience as well. This was the superiority of this molecule as compared to zoledronic acid for prevention of SRE. And here, various malignancies were included, which included the classical breast, prostate, but lung, myeloma, renal, small cell, bladder, rectal, colon. And it was again seen that there was a difference of about 8.21 months when you used denosumab as compared to zoledronic acid for a first SRE, and this reduces the risk of first SRE by 17%. Efficacy was demonstrated for first and multiple events and across all the patient subgroup, and disease progression and overall survival was similar between the two treatment arms. In contrast to zoledronic acid, it did not require the monitoring for renal status because we know that it's renal safe. But hypocalcemia is something we really are bothered, because hypocalcemia is more common with denosumab because it has a much stronger action, and ONJ occurs in both at a similar rate. So again, emphasizing the fact that one should actually check for the dental part before beginning these anti-disruptive measures. Next slide. So this was the pooled trial evidence, and you can see here in terms of the time to first SRE, time to first and subsequent SREs, renal toxicity, and acute phase reaction, everything favored the denosumab arm. However, if you talk about hypocalcemia, it was less with zoledronic acid. So that is something we really need to correct before giving any of these agents. And ONJ, though it was nearly similar, but it favored the zoledronic acid arm. And the OS and the disease progression was not really different between the two arms. Both of them were helping similarly. So denosumab actually delays the skeletal complications and spares the renal part. And zoledronic acid carries lower hypercalcemia and ONJ risk. So you can basically, these can be some things, points to do some berry picking as to what to choose in your patients. Next slide. So what would be the key clinical takeaways? We know that the use of hormonal therapy, which includes the AI, increases the risk of fractures in breast cancer. We need to have the agent of choice for managing bone loss and preventing fractures. And we have zoledronic acid, alendronate, risedronate, and denosumab. We have seen that denosumab in a 1 6 monthly dose at a dose of 60 mg is recommended for improving bone mass in women with breast cancer who receive AI treatment and are at high risk of fractures. And denosumab, obviously, as I've told in my previous slides, has certain advantages over bisphosphonate. The major one being that you do not require any renal monitoring, and it is easy to administer, and the safety profile is very well established. Next. In terms of the metastatic bone disease, denosumab is superior for SRE, 18% benefit due to risk of hypocalcemia worsening. Calcium and minerals, which is magnesium and phosphorus, should be monitored for 14 days after denosumab administration, and we should monitor magnesium as well. Serial dental examinations at at the beginning and serial are something which is must as a precautionary dentistry measure to avoid ONJ. And when denosumab is planned to be stopped, a rapid transition to an alternative anti-resorptive agent should be advocated to avoid undue fracture risk. Because the thing is that since it has the reversible effect, the moment the brake is removed, the metabolic activity would start further and it would start very fast. So when it is planned to be stopped, a rapid transition to a milder anti-resorptive agent should be considered. It is not that you just stop it blankly. Next slide. With this, I thank and I hand it back to the organizers, to Genova.
Thank you so much, sir, for this wonderful presentation. And we will get back on the panel discussion regarding osteoporosis in cancer patients as well. Before that, would love to invite Dr. B. Ravishankar sir to take us through From Pain to Protection, New Frontiers in Oral Mucositis Care. So, sir, of course, is the head of clinical oncology and managing director at Omega Hospital, Visakhapatnam. Sir is a distinguished clinical oncologist with 32 years of experience and is a dual specialist in medical and radiation oncology with extensive experience in clinical research, academic medicine, and multidisciplinary cancer care. Sir, over to you for taking us through this important topic of from pain to protection, new frontiers in oral mucositis care. Over to you, sir.
Thank you very much, Ronak. Very good evening to all the speakers and the delegates who have joined us. This is very interesting topic, but it's mucositis is such a common complication, and where we don't find any proper answer, and we still struggle to have a proper medication for oral mucositis. Next slide, please. So these numbers are actually from the US, I think, if I'm not wrong. But in general, as a radiation oncologist, when I treat somebody with head and neck cancer, the incidence of oral mucositis varies depending from site to site. That means we have a lot of subsites in head and neck cancer. The higher incidence of mucositis is seen among the patients who have oral cancers like oral tongue or buccal mucosa or gingival or retromolar trigone. But little lesser chances when you are treating hypopharynx and larynx regions. But definitely the techniques that we followed these days, like IMRT and all this VMAT, have come down the incidence of mucositis among the patients who are suffering from head and neck cancers who are undergoing treatment. But we also see a lot of patients having mucositis with chemotherapy. But the chemotherapy incidence is a bit low compared to the targeted agents that we have today, a lot of tyrosine kinase inhibitors, which can cause mucositis. Next slide. So definitely it's really a big problem. We can imagine if you have a small Alka-Seltzer in the mouth, how much pain it would cause. Similarly, a mucositis is really a debilitating complication, especially among the patients who are suffering from cancer, whether they are undergoing radiation or chemotherapy. It can manifest as an erythematous lesion, and it can, progress into an ulcer, and sometimes it can also get infected with a superadded infection. And this mucotoxicity produced by chemotherapy can be a direct damage to the mucosa through the stem cell damage, or it may be indirect by way of immunosuppression, leading on to oral mucositis, maybe fungal agents leading on causing oral mucositis like candida or some other agents, and nutritional deficiencies. So if you want to really look at this risk categorization, there are certain factors which can, put your patient into a higher risk for mucositis. Coming to the patient-related factors, we have you have a patient who has poor, uncontrolled systemic disease like diabetes or any other debilitating like immunosuppressive disease, HIV or something like that. They are the ones who have a higher risk of having oral mucositis compared to a normal individual. At the same time, if somebody has got poor oral hygiene and reduced salivary function and poor oral habits like tobacco chewing, which is very common and prevalent, you can see among our patients, which can change the oral microbiome, and also it can predispose this patient for a higher chances of oral mucositis. And they have a medium to moderate chances of having mucositis. And somebody who has got no oral complications or no systemic diseases with good oral hygiene, they have a very lesser chances of having a mucositis. And coming to the treatment related, somebody who is getting a head and neck radiation, they have a higher chance, especially oral cavity, oral tongue, buccal mucosa, treated with high dose methotrexate or cytarabine. They have a very high chances of having oral mucositis. And radiochemotherapy before stem cell transplant, they have a very high chance of again the drug what they use for before transplant for stem cell transplant, that also depends on the severity of the mucositis. And definitely this radiotherapy, especially a palliative radiotherapy or radiotherapy combined with targeted therapy, can also have moderate chances of having mucositis. And somebody who is not receiving any systemic anti-cancer treatment, they have a very low chance of having mucositis. Next slide. So definitely there are certain phases by which the mucositis progresses from initial stage where there is an insult to the mucosa by oxidative stress, and it progresses slowly and by reactive oxygen species or through NF-kB signaling pathway or by stimulation of pro-inflammatory cytokines. Slowly it will progress into ulcerative phase. And then there is a phase called an healing phase where the epithelial cells proliferate and migrate to restore the tissue. But this healing phase always depends on the amount of stem cells that you have. So usually radiobiologically, what happens is when a patient is subjected to radiation, the mucositis severity depends on the stem cell damage. Next slide. So there are certain criteria by which you can say whether what's the grade of mucositis that the patient is having. And majority of us, either we follow WHO or RTOG, where initially there will be an erythema or mild pain, usually where the patient does not require any kind of an analgesics, and slowly it will start ulcerating, and patient will be able to take only semi-solids. And then as they progress, the severity of the mucositis increases and there will be more pain and you'll be able to take only liquids. And then in grade 4, there will be patchy ulcers and severe pain. Whereas in RTOG, in grade 4, there will be ulcer formation. Next slide. So there are two aspects which we have to understand whenever we talk about mucositis. One is prevention and the other one is treatment. When it comes to prevention, you need to have a thorough risk assessment before we start the patient on radiation, especially oral hygiene. Oral hygiene is very important, and patient has to have a dental checkup, and complete clearance from the dental surgeon is very much required to reduce the oral mucositis in these patients. And then there will be some kind of an oral topical applications may help us to reduce, and I'm going to tell you what it is. And then if there are some systemic drug patient is on, and then we have to see whether that has to be continued or not when the patient is started on radiation. And then when it comes to the treatment, you need to assess whether what is the grade of the mucositis that the patient is having. Basing on that, you have to start the patient on treatment. Usually a treatment is according to the patient's symptoms, and we need to communicate with the patient whether what kind, and you'll have to see what kind of a nutritional support the patient is requiring, because usually it's a vicious cycle. So once the patient develops mucositis, there will be nutritional depletion, and then because of the nutritional deficiency, again this mucositis can get worsened. So you need to have a kind of an understanding about this, and then if there is a requirement, you have to put a Riles tube, and if there is a requirement, you have to put a FJ tube in order to maintain the nutritional support, by which always you can help the patient to improve. One is you can bypass the passage by using this FJ or Riles tube, and second thing is you can maintain the nutritional support. Next slide. So basically, this is so first evidence-based in a previous one. This is the first evidence-based clinical practice guidelines related to oral mucositis was published in 2004 by MECs. And then subsequently, there are so many publications like ISMO, and there is also publication from China, CSTRO, where they have given basically to understand how to go about, like mostly it is oral gel, or in the form of local application of glycerol or something, and then sucralfate. And then later on, we got some information that L-glutamine also improves the repair of this oral mucositis. But as of now, we do not have a substantial evidence to say that this particular drug is really helpful in improving the mucositis. Next one. Next. So this oral mucositis is no longer an individual problem. It's a national healthcare obligation, particularly in patients suffering from cancer. So here what happens is the healthy oral mucosa, you can see that there is no breach in the barrier. So once the patient develops mucositis, there is always an ulceration, and then the injured oral mucosa need to be protected. So you need a layer by which it protects the ulcer and allows the mucosa to heal. At the same time, the nerve endings which are there need to be protected, by which you can reduce the pain. This is the hypothesis behind using these kind of substances. Next one. So this is basically a bioadhesive gel where it has shown in the management of oral mucositis who are undergoing chemoradiation of head and neck malignancies, which was published in 2023. So you can see that these are, emerging novel therapy by which you can use in patients who are undergoing radiochemotherapy, where the mucositis can be managed effectively by using these bioadhesive gels. Next one. Okay. See, basically here it is like you need something to protect the mucosa, and you need something to reduce the pain, and you need something to allow the mucosa to heal. These are the main concepts behind using a combination of bioadhesive gel. Here it coats the oral mucosa, it enhances the tissue hydration and accelerates the healing. Next one. So you can see that when these 30 patients were subjected with chemo RT, when they used this bioadhesive gel, the mucositis changes have come down drastically, and patient's pain response is also better, and patient's functional ability is also much better compared to the patients who have not used. Next one. So this is very interesting one. An antimicrobial ingredient which was used reducing the plaque accumulation and inflammation. Here they have used an antibiotic, and very recently, if anyone knows, I don't know, but the usage of mupirocin ointment, a nasal formulation, was used in patients undergoing radiation therapy and chemotherapy for nasopharyngeal carcinoma. This article was published in September 2025 in JCO. So mupirocin reduced mucositis pain during the time of radiation and allowed the patients to have a better outcomes. The idea is, they say that if you use antibiotics, there is something called oral microbial dysbiosis. So that can be overcome. So basically the bacterial agents which are like fusiform bacteria and all those things can be reduced, and by which you can allow the mucositis to heal in a better way, and the pain is also reduced. This is what has been published in JCO about mupirocin. So here we have another antibiotic where they have combined with other agents like hyaluronic acid and glycerin. So this three triplet combination has really worked well, and I have used in a few of my patients. Unfortunately, I don't have, I have not taken any pictures, but it has really helped them to improve their mucositis in clinical setting. Next one. So this is an observational phase 4 study where 89 patients were receiving chemotherapy. So here also you can see that there is a significant improvement in local findings, and mucosal ulcers were significantly lower. Patients who used this drug, and average intensity of pain is also reduced. Next one. So this is glycerin. It's a lubricant and emulsion that provides smoothness. Many of us know, even before joining into medicine, like whenever we develop aphthous ulcer, I still remember, but we used to use glycerin, just we used to put it in the oral mouth. So that relieves the edema, and it allows it, it's emollient and soothes it and reduces the pain. That's what we used to use. Similarly, the same thinking, I think probably they have used this combination. Next one. So here again, in another study, it has shown that significantly higher number of patients developed grade 2 mucositis, and a higher number of patients control arm also required opioid analgesics compared to the other. Next one. So this bioadhesive gel, it is a combination of three, that is glycerine and hyaluronic acid and antibiotic. One, it soothes and retains the moisture and protects it. It forms a layer by which it protects the oral mucosa, and this antibiotic allows the mucositis to heal by reducing the bacterial load. Next one. So, yeah. So the combination is like when you're using glycerin, it is lubricant and moisturizer. It causes moisturization, and sodium hyaluronate, it tissue repair and barrier formation. And the antibiotic is antiseptic protection. It reduces the microbial colonization. So by which effectively you can reduce the oral pain, and you can, dysphagia can be reduced, and need for analgesics also can be reduced, and the patient's oral intake can be improved, and the quality of life also can be improved. Mucositis healing is much faster. More than anything, it gives a kind of a confidence for the patient that he can continue the treatment. This is what happens, this mucositis, when it starts in the middle of the radiation, many of these patients, they don't want to continue, they wish to discontinue the treatment. They just want to go back to the home and say, I can't bear this pain and I can't continue. This is what happens in many of our patients. So this gel is very effective, and it reduces the pain by at least 30 to 40%. That's what I can say. I cannot say more than that, but it allows the patients to have continue the treatment. That is what is important for all of us. Next. So this combination is stronger than a simple moisturizing gel. It relieves the symptoms, mucosal healing, and infection control. Thank you very much.
Thank you so much, sir, for this wonderful talk. And I think now we can move to the final segment for today, where we'll have a panel discussion talking about the future of supportive oncology, innovation, access, and impact. And to do the same, I would love to invite Dr. Pranav Chadda, sir. Sir is a consultant radiation oncologist and theatric radiotherapy radiosurgery at the Kokilaben Dhirubhai Ambani Hospital, Mumbai. Sir is an experienced radiation oncologist with 17 plus years of experience and has been having a special focus in radiation oncology, radiosurgeries, radiotherapy, etc. Sir has more than 300, more than 2,000 image-guided radiotherapy procedures, 500 plus re-irradiation procedures, and Sir is a faculty and the program convener of the best of Astro as well. So over to you to guide us through the panel discussion for today.
Yeah.
And it's a pleasure to invite this panel, lovely panel here as well. So over to you.
Yeah. Thanks. Am I audible, please?
Yes, sir.
All right. Okay. And greetings to my panelists. And it's going to be more of an informal discussions. We'll be discussing with regards to the denosumab and the biodiesel gel, which the earlier speakers alluded to. I'll just share my screen and let me know that if you're able to see. Is my screen seen now?
Not yet, sir.
All right.
Yes, sir. We can see the screen.
All right.
The full screen.
All right. So the first section of my panel discussion, the discussion that I'm going to have, is going to be on bone health. And feel free to chip in. And it's just going to be some sort of practice points along with some of the evidence. So, so if I may ask, to start off, if I go alphabetically, Dr. Akshay, what patient-specific factors do you see to decide the baseline DXA scan before the treatment initiation in your clinical practice?
Hi, good evening.
Good evening. Hi.
Actually, in old age patients, especially in females, post-menopausal or perimenopausal stage,
Right.
and who has taken any chemotherapy or has taken any radiation which ceases their ovulation, or they're having menopause at early from the normal age,
Right.
or if they are having deficiency of vitamin D, And if I am planning to start and then in AI, then I can have a baseline DEXA scan for them as a routine.
Right. If I may just add, is there any age cutoff in which you would compulsorily or sort of mandatorily do a DXA scan? Any age
In females,
criteria?
I would like to like do a baseline DEXA scan in 45 to 50 years of age at least, patient crossing 45 in females, and in males in 50.
50. Right. Dr. Abhishek, anything from your side if you would like to add, sorry, with regards to the patient-specific factors that in your practice you would like to decide?
Sir, I'm not very much comfortable with the DEXA scan, although we have a official policy that we have to go with the DEXA scan for our patients who are undergoing hormonal therapy and chemotherapy in our institute. So for each and every patient, I have to go for the DEXA scan as a baseline investigation.
That's very good. So that solves the problem. All right. So let me just highlight what I've read. So this is as per the guidelines. So one set of guidelines says one thing, the other says the other, but this is more or less accepted that women aged 65 years and old, men aged 70 years, regardless of any clinical risk factors, you kindly do a DEXA scan. Postmenopausal women and men above, men aged 50 to 69, younger postmenopausal women, and women in the menopausal transition, as Dr. Akshay told, based on some risk factor profiles. Postmenopausal women and men age 50 and older who have had an adult age fracture. So this needs to be sort of highlighted to be, it's an underscored point to determine and sort of diagnose the degree of osteoporosis. And adults with a condition like rheumatoid arthritis, taking medications like glucocorticoids for some other reason, or equivalent to that prednisolone, especially, which can be associated with a low bone mass or a bone loss, for that matter. Dr. Jogmai Patnaik, are there any the risk factors? Would you sort of allude to any of the risk factors that you would think of? The usual, I think, but we might miss. So would you sort of think of taking those into account?
Sir, any patient who is having diabetes for a long time and
Right.
thyroid abnormalities for a long time, like hypothyroid,
Right.
on thyroxine supplementation, those are
Right.
also being considered to do bone scan.
Right. And so a couple of things to be added,
And
like
chronic kidney disease patients.
kidney disease. So yeah, so this is as per the clinician's guide, and they sort of tell that you also take into account the low BMI, smoking, alcohol. I think the usual good clinical practice that we don't forget with regards to the bone health. All right. Any cancer types first to order a DXA scan where you would think. So the cancer type probably here would mean a metastatic disease, which is common sense. But if I may ask Dr. Archana, if any cancer that you would specifically like to order a DXA scan along with the patient factor.
So it is usually, we all know breast cancer and prostate cancer patients, especially breast cancer patients, postmenopausal women, where we are going to start an AI, letrozole or anastrozole. There we are asking for a DEXA scan. Sometimes in other patients also, where again, postmenopausal lady on glucocorticoids due to some reason or the other, maybe rheumatoid arthritis is there. Or sometimes even in male patients, when prostate cancer patients, we are planning for giving ADT, then again, bone tumors, multiple myeloma, then metastasis, extensive metastasis, especially lytic lesions, if we are expecting.
Right. Totally get your point. Dr. Swapna, if I may ask, the treatment regimens when you're sort of contemplating, as Dr. Archana said, supposed to start an AI in a postmenopausal breast cancer lady, or anything else which you would like to tell us?
Like aromatase inhibitors when we are starting. So apart from DEXA scans, first I will think of the common vitamin deficiency, which is more common in Indian areas. So the vitamin D and the calcium we have to order for the test. So then both in breast cancer going for the aromatase inhibitors, and also in the men with the prostate cancers who are going to go for the androgen deprivation therapy. So we should go for the DEXA scan and calcium and vitamin D. So according to the initial before start of treatment T score or the Z score, so we should plan for the bone bisphosphonates or the denosumab.
Right. Right. Dr. Wilson, Dr. Lavin, anything from your side? I've just sort of popped up the list, but anything with regards to chemo? I think this is more of a medical oncologist purview, that with regards to any of the medications that you'll be careful, probably cyclophosphamide or anything else which you would like to tell us.
Yeah, means mainly the chemotherapies that are known to cause more ovarian suppressions, like doxorubicin, which is mainly used in breast cancer. In all this disease, regimens will definitely have a DEXA scan and look for osteoporosis. Other than that, those patients who have requiring a long-term steroid use more than 3 months, in those cases also there we'll plan DEXA scan and monitoring for osteoporosis in such cases.
Right. So if I may ask my radiation oncology colleague, who's Dr. Archana and Dr. Swapna, if a bone is osteoporotic, suppose a femoral bone, Dr. Archana, if I may ask in this relevant point, and there are some scores like the T score and the Z score. So the T score is really bad. I would go into the numbers. Would you, and if it's showing metastatic disease and the patient is in pain, would you like to treat the patient with radiation field there?
So again, see, we have to see whether number of metastasis, bone health of the patient, pain. Now the thing is, if the patient is having a lytic lesion and it is a weight-bearing area, so we need to address that specific part. So in that case, we have to think about treating that area.
All right. Okay. So you'll still go ahead with that, but you'll give some sort of support or some sort of care to that region which is already osteoporotic, which might be there, which probably is
so that is the main purpose of doing it previously, so that you come to know that this is the area, this is the weight bearing area, and we need to look out on this area specifically, and we have to advise the patient also accordingly. It shouldn't be that he is careless and the bone gets fractured and we land up into some sort of compressive myelopathy or something like that.
Makes sense. Dr. Sapna, any difference of opinion, or would you like to disagree?
So we have to balance whether it is because osteoporosis also can cause the fracture and our metastasis also can cause the fractures. So we should balance and we should estimate. You see, it is like an individual patient plan. And first we should try with the bone like medical management, like denosumab, or with that bone strengthening agents we should plan first. And if it is some strengthening exercises, if possible, then we should add, and we should check for the vitamin D and calcium. And wherever, if surgery is possible, there we first prefer the surgery rather than the radiation, because radiation-induced osteoporosis is quite common. It may lead to the fractures. It may enhance the fracture problem more.
Get it. Totally get it. All right. Any red flag symptoms in the clinic, Dr. Akshay, coming back to you, just to investigate, just good clinical examination, anything which you look for. Now, this is a pertinent question regarding to hip and the spine. So anything which you would like to say?
I would ask about any old trauma, history of any trauma. And if there is any pain during mobilization and in any kind of pain which persists which is especially localized to a point. Then I should ask for the investigations.
Makes sense.
And if I am doing a PET scan which is showing already metastatic disease to bone, then I can ask for DEXA scan too for getting a bone health, for which I may plan a treatment or including the radiation of that part. So a patient should be like concerned about the
like about they can get a fracture despite of the treatment, despite of the precautions,
Right.
because disease is already high risk, or it may be a high risk disease, or disease may progress despite the treatment. So for preventive part is also very necessary for preventing the morbidity of the treatment and for the causing less pain to the patient.
Right. Dr. Abhishek, anything related to spine that you think it is a red flag and you get worried, or you take some
Yes, sir. Whatever Sahai sir said, I agree with that. One point to add that any new onset pain will be a red flag sign for impending skeletal injuries.
Okay.
So any issue, any fracture caused by a tribal trauma can also be a red flag sign.
Right.
That to be considered, that if the patient is complaining of this type of thing and they're having pathological fracture type of thing, then we have to be careful about that.
Totally get it. Okay. Okay. So so the cancer treatment induced bone loss, which the previous speaker also spoke about. So, and as Dr. Swapna said, that you need to be sort of take care of the calcium and the vitamin D supplementation. How much and when? These are the questions which have been addressed by the American Association for College of Endocrinologists and the Institute of Medicine. So there are certain doses that we just need to look and prescribe. With regards to weight bearing and strengthening exercises, this again has been recommended so as to take care. Any difference of opinion from anyone? This is an open-ended question. Whenever a weight bearing bone, say femur, comes with a metastatic focus, do you tell your patient to sort of stop walking, become less ambulatory? These are practical questions and practical viewpoints. Or do you suggest otherwise? Anyone, it's open to the forum. Anyone can answer this question or give an opinion with regards to the weight bearing. Would you tell the patient not to walk, or would you tell the patient to do some weight bearing and strengthening exercise? How would be your outlook? Anyone, please.
May I?
Yes, please, Dr. Please.
For this particular scenario, when the femur is involved, patient should be taught with the should be consulted with a physiotherapist, and particularly trained for weight bearing exercises.
All right.
Especially how to get up in the morning from the bed, especially how to get up on the chair when he's sitting or she's sitting on the chair.
Yes.
So 2 or 3 things when the time or position being is on dependable from supine to prone position, we have to lock turn manner is used. So the two or three things should be told to the patient that these are the precautions that you have to take on a daily basis. And if feasible, mild exercise training, muscle strength training should be advised to them.
Makes sense.
Both for the skeleton and for the spine also.
Correct. Anyone from a technical point of view would say no, don't walk. What findings would you look for in imaging? Anyone who would like to say?
So any impending, like impending fracture, or a patient having complaining of radiculopathy or something like that. Then in those cases, I would like to first address the main issue, because if a impending fracture turns into a compressive fracture, that it can cause paraparesis and those cases. So in those cases, I won't advise strength training, and I'll advise rest and take an interventional radiologist opinion also, whether we can do some kind of vertebroplasty and or stabilize the lesion before doing all this preventive measures. And so that is the one thing that I'll look into.
Yes, so to be succinct, weight bearing and strengthening when it is not that bad, and not to do when it is really bad, like an impending fracture or an impending cord compression. The medical interventions, which are again part of to take care of the which one to decide when and when not to. We'll go to the next slide. These are the recommended calcium and the vitamin D doses, which we can read from any of the literature source. All right. Which one to decide when and when not to? So we've heard about the evidence about denosumab, but still lytic lesion in a myeloma patient, lot of lytic lesions, more for the medical oncologist. Dr. Jogmai Patnaik, what would you prescribe? The kidney functions are fine. There are no crack features. Would you still like to go ahead with denosumab?
For multiple, actually data for denosumab also is there for multiple myeloma.
All
But
right.
I have more experience with zoledronic acid,
All
so
right.
we'll consider zoledronic acid first. If the patient has progression on zoledronic acid, then I will consider denosumab.
So your first line would be zoledronic,
If
right?
if the
with
patient
crack-
doesn't have a renal dysfunction, if renal
Renal
dysfunction,
dysfunction.
definitely denosumab first.
All right. Suppose the patient has renal dysfunction. Then is denosumab safe? What points would you look for so as to be careful while prescribing denosumab specifically?
I will definitely look about what is the calcium level, what is the creatinine level, and get a dental examination prior to starting of denosumab. And obviously monitor for hypocalcemia. A patient who has hypercalcemia at the presentation, definitely
Right.
denosumab will be the first choice
All right.
rather than zoledronic acid.
Right. Rightly put. Okay. So these are the two strong recommendations from the ACP with regards to osteoporosis, generalizing it with known osteoporosis to reduce the risk with HIP and alendronate. In fact, the first generation of bisphosphonates, zoledronate or denosumab can be used. In postmenopausal women, estrogen or estrogen plus progesterone should not be used to treat the osteoporosis. And there are a couple of weak recommendations which are more pertaining to the bone marrow density guidelines. So this we can read from the ACP publication which had come up with regards to osteopenia and progressing into osteoporosis. The pharmacological therapy. So this was the subsequent slide that I was alluding to. The bisphosphonates, we started from oral, then alendronate, pamidronate also was there. Now zoledronate has become the standard. The RANKL inhibitors, which is the denosumab, is the flag bearer. There are a couple of others like the PTH analogs, teriparatide and abaloparatide, which are not yet established because of some adverse effect profile. A new kid on the block is romosozumab, anti-sclerostin antibody, anabolic plus anti-resorptive, which actually is ideal because it works on both the ends. And calcitonin has also been used. Most evidence-based is zoledronate and denosumab. Now the next question would be: should denosumab in the practice, should it replace zoledronate totally, or are they still complementary? Some of this sort of concept was addressed by Dr. Mohit. Dr. Archana, would you like to answer this question? Should it replace zoledronate? Let go of zoledronate, like we let go of pamidronate. Yes.
Okay. So, right. So, as Dr. Mohit had already pointed out, in a few of the scenarios, it is zoledronic acid which is superior, and a few of the scenarios, denosumab. Now, we all know, first of all, cost is one of the major concerns, especially in our country. Zoledronic acid, we all know it's one of the cheapest that we have, though denosumab is a costly one. That is one thing. Secondly, the hypocalcemia. So it is caused more by denosumab. Then again, osteonecrosis of the jaw. Now he already pointed out that one of the patient who was on denosumab had marble-like bone, and there was, impending fracture was there. But once it was stopped, the remodeling was done. So that is the beauty of this molecule, that remodeling is done, which we know that zoledronic acid doesn't give. So both the molecules, I won't say that one can replace the other, though denosumab is considered to be a better molecule than zoledronic acid. But still, seeing the cost wise and the other things, we cannot completely eradicate using zoledronic acid.
All right. So again, this goes to both the med and the rad-ons. How long then you need to give zoledronate? Dr. Swapna, please, if you may take the question.
Zoledronic acid, sir?
Sorry, denosumab. Denosumab. How long would you prescribe to a patient?
We have to check, sir, serial monitoring of the osteoporosis or the bone on DEXA scan. Then if as sir said, if it is getting marble-like or more evident, then we should stop in a sequential way, not in a sudden way. shifting to other anti-resorptive therapies. With the serial evaluations, we should.
So, if I may say that, should it be continued indefinitely till we get any adverse effect profile? Would you agree to this?
No.
No, fair enough. So maybe you'll prescribe it for 2 to 3 years. What would be your sort of
usually, like in prostate, when we are prescribing ADT, usually we will prefer to give for 2 to 3 years.
All right.
Once in 6 months.
Fair enough. Couple of these, I would call them newspaper clips, looks like them only. So people have sort of compared zolidronate and denosumab, and things have been better with denosumab. Similarly, the survival impact of denosumab versus zoledronic acid. So the trial which was mentioned by Dr. Mohit, the Fiazi trial, did not have any impact on the overall survival. Let's know the caveats of the trial, and the subsequent SREs were also similar with regards to zolidronate and denosumab. The first SRE, yes, denosumab proved a superiority, but the subsequent SREs, denosumab wasn't better. With regards to prostate, I think this Fiazi trial, which has been already spoken of, and now a systematic review and meta-analysis, which says the SREs and the symptomatic skeletal events are better with or lesser with denosumab. Also with lung, subgroup analysis, again, it's a subgroup analysis, the caveat is there, but yes, it makes sense to sort of add denosumab. With regards to myeloma, this was a non-inferiority trial which was done, and it still makes sense, as panelists has said, Dr. Jognath, that it makes sense to prescribe denosumab in this situation as well. All right, the caveats, I think I'll just put this up. The rebound lumbar vertebral fractures have been seen even in that Fizazi trial, and these vertebral fractures are often multiple and occur within months of the time. Should be continued indefinitely or followed by bisphosphonate therapy if not contraindicated. Any Dr. Akshay, if I may ask, any side effects if you have seen while prescribing denosumab to your patients, which you have noticed? Any
Actually,
ORJ?
Hypocalcemia I've seen very commonly,
right.
Which can be treated by supplementing the calcium and vitamin D. And oral, like osteonecrosis, I haven't seen till. Especially one patient, well, I was in Allahabad, Kamla Nehru. One patient was having a history of buccal mucosa. He has received CTRT, and then he has developed secondary prostate cancer.
Right.
After 3-4 years, he developed mostly due to post-CTRT effect to the mandible. And he has 70 degrees of radiation also.
Right.
So it might be.
Might. Dr. Wilson, any comment from your side? Anything you've seen? Because Dr. Wilson?
Yeah.
Yeah.
So denosumab, usually many tolerate well. Zolendronic, sometimes what we take for granted is the flu-like symptoms that appear.
Yes.
And that is quite common. And if we are able to take and prophylactically tell patients that you can take a paracetamol or something like that, that helps in such a scenario. It usually goes under the radar. Others, if we take proper precaution and all this thing, osteonecrosis in other patients who have not received any radiation also is very less, and both are very easy to use drugs.
Right. Any of us have used any newer agents? If any of us, like using teriparatide, any of us? I haven't, so I'm just asking. Or romosozumab, any one of us has used it? Just asking for curiosity's sake.
No.
No. Okay. Any one of us has seen a bioactive glass being used in biomaterials, especially in osteosarcoma, from our surgical colleagues? No. No, I presume no. All right. Okay. All right. The optimizing the dosing schedules, again, to stop denosumab, then to take care that there is a rebound lumbar fracture and to take care of the the fracture risk. So we probably might have to supplement it with bisphosphonate if the bone health is still not improved. All right, the next panel discussion on oral mucositis. If I may ask, Dr. Archana, if I may ask, can we distinguish, this is a common finding, Dr. Ravi Shankar quite sort of elusively detailed it, but can we distinguish chemotherapy versus radiation-induced mucositis? Can you see from a clinical point of view and tell that, look, this is chemotherapy-induced versus radiation-induced mucositis?
No, I don't think so. We can make out a radiation induced. Only thing is sometimes if it is oral cavity, skin changes you can make on the outside, buccal mucosa, the skin may be dark, and then you can maybe come to know that it is due to radiation.
Okay. So I'd just like to put in a word here. So we give 2 sessions of radiation, and if it's a concurrent chemo, the patient also receives chemo. And if the patient develops any sort of mucositis, it is not radiation induced. It takes time. For even with conventional techniques, it takes time for the mucositis to appear. So that needs to be educated to our patient that it will not come after just a single session. Yes, it can come after the first cycle of chemo. It is rare, but definitely not the radiation. All right, location. Anything on the location? So can occur elsewhere. Chemotherapy-induced mucositis, as we see in definitive chemo, the patients receiving it looks more like generalized redness. The radiation is generally in the radiation field path. The chemotherapy is linked to a low white blood cell count. With the redness, the erythematous mucositis, if we see the blood counts being low, then it is generally chemotherapy induced. Radiotherapy is dose dependent and it takes time. It hits nearly 100% of the hereditary cancer patients. It takes time to heal as well. So the radiation-induced mucositis also takes time to heal. Interventions, Dr. Ravi Shankar, he sort of again told, this is what I got from a current oncology opinion, and there are 2 things that we need to take into account. So from a radiation, this question goes to Dr. Swapna. Do you what do you start prescribing, if I may ask, in your practice to reduce the incidence of oral mucositis? Do we start with the good old gold standard, the salt and soda, or do you add something from the day one?
No, for the first, before start of treatment as a preventive measure, I will send the patient for the dental prophylaxis, sir.
That is done. Yes.
Dental prophylaxis is done.
Yes.
The
Yes.
first day itself, we usually starts with because the mask guidelines, supportive guidelines, if we see, the recommendations are like Benjamin mouthwash is there if we are planning for the less doses. So and there is a salt and soda water gargles.
Right.
And in my practice, we usually here since 1 year we are using the even photobiomodulation therapy, sir.
Oh,
with the low infrared laser therapies.
All
We started as a
All
thesis purpose. We have started and we have seen good results. We are continuing this one, sir.
Right.
From the first day itself, we start with this one, sir.
All right.
And
Doctor,
adequate patient education about the hydration and
right.
Maintaining of the oral hygiene. These are also very, these also makes very much difference to prevent the mucositis.
All right. Anything from a medical oncologist perspective, Dr. Abhishek, anything which you would add to either during concurrent chemo rads or in a definitive chemo setting?
Sorry, sir, I missed the question actually. Please, can you repeat for me?
To reduce the incidence of oral mucositis, either in a concurrent chemo rads or definitive chemo setting?
Okay. As such, the general well-being of the patient, the diet of the patient, the protein intake of the patient will determine these things particularly. So if we focus upon the dental hygiene, orodental hygiene, the good nutritional intake, good water intake, this may help in preventing in both the scenarios. And particularly in radiation, we are expecting that the radiation-induced mucositis will develop after 2 weeks or at least 2 weeks after the commencement of radiation. And the chemotherapy will start after the cycle of chemotherapy and will settle down once the counts come to the normal.
Right.
So we can plan the things accordingly, that we can prepare the patient that after 2 weeks we are expecting that you will develop mucositis after radiation. So you can prepare the things accordingly and maintain the oral hygiene and the nutrition.
Right. So this slide is a copy-paste slide.
I may intervene, can I?
Yeah, please.
Like we were discussing about prevention strategies, constraining the dose to the oral cavity, the mean dose to the oral cavity from a dosimetric perspective is another way of trying to mitigate the mucosal inflammation. That is also to be added.
Right.
Sir, this
Sir,
I think we can discuss on this, because compromising with the dose in a setting when we are planning for a definitive treatment
No,
is not really the first option.
not at the expense of the PTB. I'm saying that the part of oral cavity that is outside can be constrained, and that strategy helps a lot.
I may sincerely apologize, Dr. Satish Balachandran.
Yes, sir.
Right, you're a radiation oncologist?
Yeah.
All right, so I'm sorry to have missed you, and trust me, the best people always come in the last. This is what and thank you for putting up this point. This is a very valid point that you've put in, because if you draw the oral mucosa, now since we have intensity modulation, and I couldn't agree with you more, if you put in a constraint for the oral cavity, we let the physicists work hard on that. Yes, that is the best way to reduce the incidence of oral mucositis. Totally agree with you. Totally agree with you.
Sir, we have tried, like one nursing thesis was going on in our chemotherapy daycare, and what she was doing, she was putting ice chips when the patient was receiving chemotherapy. So we saw that some reduction in mucositis risk that can be done on preventive strategy.
That is in the Memorial Sloan Kettering guidelines as well, to use ice chips as and when required. All right, this is a copy-paste slide that I've put in. Pardon me for that, but you can see from both the columns that you can reduce the severity and reduce the incidence, and more or less the same the agents which are there with regards to radiation, chemo, as well as chemoradiotherapy. All right. Role of bioadhesive gels makes sense also from the skin point of view, where it came up first. And it had a barrier protection, pain reduction, extended retention, moisture retention. So if I may ask Dr. Satish now, have you used any of these gels in your practice, Dr. Satish?
Not yet, sir, no.
Not yet. So what do you use if there is a grade 2/3 mucositis? What would you suggest, like a prescription?
A combination of an analgesic, or if it's very severe, I will add an opioid for the patient, benzidamine mouthwash, and a salt and sort of bicarbonate. And in my practice, if it's very severe, I put them on a course of steroids if it's very difficult to manage.
All right. Anyone like to disagree with the steroid with Dr. Satish, please? Any radiation oncologist, please, Dr. Archana or Dr. Swapna?
So again, you have to see if there is a fungal infection or something like that. Steroid is a definite no in that case. But yes, if the patient is not diabetic, you can fairly you are clear that there is no fungal infection. Then yes, definitely steroid are one of the best agents that we can use. Sometimes even some steroid tablets we crush and give it as a gargles to the patient, and they are very helpful. Rather than giving systemic steroid, we can just give them oral steroids like that.
So it was a rhetorical
question. Also tried honey also, and it to some extent.
Everything has. Yes, I use sometimes clarified butter and honey combination, ghee and honey. Let me confess, and it sometimes works for grade 2 mucositis. It does.
Yes, sir. Yes.
Right. Past guidelines and honey they have given as a level 2 evidence, sir.
Right. I'm sorry, but I'm using it. It works for me for certain patients, and it's quite cost effective, if you ask me. All right. All right. So barrier forming gel, a randomized control trial from China. And this is with regards to Episil, in which they found out that it delays advanced oral mucositis and oral pain. And in resource constraint, now this is going to be a question, sort of an argument, if I may say that, whether direct cost versus the indirect savings, we take a call, and then to choose. So the hyaluronate and the acetylpropylidene, which is the antiseptic, I would call it, and the salicylate, which is an anti-inflammatory, but beware that a salicylate might sometimes cause a hypersensitivity or an allergic reaction, which I have also seen in my practice. So that we need to be careful. This again in action. Future advances would be, I'm just putting out just for the sake of completion, some would be some sort of microbiome modulation. We'll be taking oral swabs, giving probiotics, advanced regenerative agents like the platelet lysate, growth factors, cellular and genetic tools. We can predict and tell the patient that, look, you're going to have more mucositis compared to your fellow patient. We need to have predictive nomograms, multifunctional formulations, and more standardized guidelines, which keep on evolving. Thanks. Thank you. Thank you for a wonderful panel discussion. Thanks to all my panelists.
Thank you so much, sir, for this wonderful panel discussion, and the expert panel again for giving us your clinical pulse.
Right.
Thank you so much. And I think, yes, with this, I think we can close for today. Thank you so much, everyone, for joining in and sharing your valuable clinical thoughts regarding these important topics of supportive care as well in the cancer treatment. Thank you so much. Thank you so much, sir. Thank you so much, everyone.
Good night.
Thank you.